So this is a man who is 55, has been referred from another center. He actually has a metastatic squamous cell carcinoma of the rectum, for which he received neoadjuvant mitomycin and capecitabine chemotherapy and pelvic chemoradiotherapy with capecitabine in 2012. He had a good response to that. 9 months later, he had a left hemihepatectomy for liver metastasis, but unfortunately developed recurrent liver metastasis quite soon after the operation and was then treated with Taxol, since this is a squamous cell carcinoma, to which he responded well, but then there was a further recurrence, and he's had extensive radiofrequency ablation performed at the other center. He's recently recurred more widely within the liver, and the other center are asking us whether he would be suitable for SIRT or whether we would consider any other therapy.
So the imaging that we have is from October the 24th, 2014, and I've put up an MR study and also a CT study, which were obtained at the same time. And we can see there's, on the CT particularly, you can see there's a very small liver remnant, which is really only the posterior segments of the right lobe, in which there are a number of metastatic lesions. So at least 5 metastatic lesions, and they have a typical appearance, certainly on the two-weighted imaging, of some central necrosis, which is of high T2 signal and intermediate T2 signal, consistent with tumour.
So we have 5 areas of recurrence and a relatively small liver remnant. We just have to check that we don't think there is a surgical option here.
Certainly not with that small remnant. And also it's poor tumor biology. I wouldn't even contemplate surgery here.
Okay, so we need to think about other options. So in terms of local therapy options, we could ablate or do SIRT. Is ablation possible or not?
I think the concern would always be the relative size of the liver remnant in terms of your ability to successfully ablate them. So you would be quite limited in how aggressive you could be in establishing a margin. So I think whilst you could ablate them, I think technically they're likely to recur simply because you would feel you wouldn't have that kind of freedom that you would want to be able to ablate
to get sufficient margin.
Absolutely.
And that's exactly the same reason why we can't consider stereotactic body radiotherapy. There is insufficient liver to have a sufficient margin. So what about SIRT as a treatment option, Phil?
I think SIRT would be a good option. I think when we were doing the workup, it would be important to try to understand the blood flow into each of those areas. This liver remnant is relatively small, at about 1 litre, and we know that patients who have small livers are at greater risk of developing radiation-induced liver disease. So if there was any way that we could identify areas of liver that had supply to normal liver only, then we could try to spare those areas of the liver and deliver the radiation just to the areas containing the tumour. We could think about fractionating the dose over a period of time and treating some areas at day 1 and then other areas later.
For safety reasons.
For safety reasons, yeah.
And since this is a squamous cell carcinoma, based on the small retrospective series, we would expect a good response to radiotherapy.
Yeah.
And so SIRT would be the preferred treatment option, I believe.
So I think on that basis alone, it would be worthwhile at least progressing to doing a SIRT workup, to looking at the vascular anatomy of that liver remnant and the relative positions of those metastatic deposits, and then thinking about exactly how we go about delivering the treatment.
Okay, so we all agreed we'll offer that treatment option to the patient.
Sounds good.
Right, so a month ago we saw the scans for this patient, and we decided that we would offer him SIRT. We've discounted a surgical option, so Mr. Silva's not here for this discussion. but we were concerned about the size of the liver remnant, a very small liver remnant with 5 lesions within that. So we thought we would do the workup procedure and then rediscuss. So what have we got following the workup procedure?
So what I've put up is this is the post-workup angio. So there's the angiocatheter sitting in the remnant hepatic artery, and the various branches of the hepatic artery, which certainly to my eye seem to be supplying tumour. The blushing that you're seeing in the liver are the metastases, and so it would appear that all the branches of the hepatic artery are supplying metastasis. I'm sure Phil will have a...
And that's what it looked like at the procedure. We used cone beam CT actually from each of those 3 vessels supplying the liver remnant to try to identify any of those branches that supplied normal liver only, but actually all 3 of them supply at least some tumour. So I think if we want to treat all of the tumour, then we're going to have to treat all of that liver remnant. In fact, initially I did the MAA workup and injected the MAA just into that main inflow artery with a view to distributing the MAA throughout the entire liver. But as we can see on the post-MAA imaging, flow has actually taken all of the MAA inferiorly into that liver remnant, and from that treatment position within the inflow artery, actually we've only treated the inferior aspect of the liver and are going to miss a significant amount of the disease. So he stayed overnight, so I brought him back the following day and repeated his workup procedure, and the only difference was the position of the injections, in that I elected to then select out each of those 3 inflow arteries separately and then deliver the MAA in equal portions into each of those arteries, and repeated his MAA study, which now shows diffuse uptake throughout the liver and very good uptake, interestingly, within each of the local deposits. So I think if we're going to try to treat him, we're going to need to treat him selectively from each of those vessels to try to control the flow so that we get activity where we need it, and try to do the dosimetry carefully in order to get enough activity into the disease without overloading what's a relatively small remnant.
Okay, so we agreed that following the second workup procedure, we have sufficient activity in the lesions to proceed with CERT, and we feel that we can do the dosimetry safely so that the patient doesn't suffer so much radiation-induced liver disease that he will succumb. So
yeah, I think so. I think it's probably worth our while using a few different dosing models and just seeing what the options are in terms of the range of dose that each of those models might give. And we'll get Darren to do that and see what he comes back with.
Right, so 3 months ago we decided to treat this young man with CERT, and following 2 workup procedures we feel we could do that safely. So he was successfully treated. He did suffer about a month of quite significant fatigue following the treatment, but he has recovered from that now. He feels well, and now we're assessing the post-CERT scan. This is 10 weeks post-treatment.
So we've got CTs and MRs pre and post CERT to look at. So again, I've left the pre-treatment image from October 2014 on the top slice, and then we've got comparing that to the post-treatment in January, and I think it's fairly convincing that the metastases within the liver are both decreased in size, and also I think it's fairly clear that they've also become a lower attenuation, and that so these are solid-looking tumours which have become apparently more liquid, consistent with necrosis with the tumour. So they seem to have responded well to treatment. Interestingly, what he's also developed in the intervening time is this nodule within his upper pole of his right kidney, which is a rather homogeneous appearing nodule. And certainly you would be concerned, although it's a very atypical location, that this would be a metastatic lesion in the right kidney. When we look at the MRI, it doesn't really help us in terms of elucidating the kidney, but the two things that we're interested in is obviously to confirm the degree of necrosis, and also to have a look at the liver parenchyma, because I think MR is probably a slightly better way of assessing the parenchyma for the
So
presence.
is there any evidence of radiation-induced
Absolutely.
liver
So
disease
I'll show you the pre and
10
post.
weeks post-cert?
And again, when we're comparing the more recent study in January, which is at the bottom, compared to the previous study in October, again you can see on these T2 weighted images that there's only a thin rim of tumour with lots of fluid within the in the centre. You know, again consistent with the necrosis that we were happy to see, and the liver parenchyma itself looks uniformly of low T2 signal, which is a feature of being spared radiation-induced liver disease. You can just about make out the renal lesion on the MRI. So it looks like a good response in the liver.
So a good response to the cert in the liver, but a new lesion in the right kidney, which may represent a metastasis. And is that new lesion ablatable?
It's certainly something that we can consider,
So
particularly
if
given a good response.
Yeah. So if confirmed to be a metastasis, we would consider ablation to the lesion. We can offer the patient that. We may need biopsy confirmation. We'd have to discuss that with the patient. And in the meantime, we'll continue to monitor the liver to see how sustained that response is. Are we agreed?
Yeah.
Okay, thank you.